Hi, I'm Duncan Ferguson. In this talk, we're going to focus on the drugs that are used to manage diarrhea, and we're going to talk about principles of and mechanisms of those drugs. So the first thing to realize is that diarrhea is, and we'll talk about this later, is not always a bad thing. When we talked about causes of diarrhea, we mentioned this. So you don't always need to specifically treat diarrhea. You do often need to treat the consequences of diarrhea, such as the fluid and electrolyte imbalance. In infectious diarrheas, it's rare, if ever, and may be contraindicated to use an anti-infective agent because, in fact, you may just perpetuate the condition itself. And then we'll talk about drugs that are used as antidiarrheal agents, opioids, antimuscarinics, some of the uh, orally administered COX inhibitors, etc. And we'll go through very detailed mechanisms about how those drugs work and when those might be most effective. Now, I'm not going to go into the principles of intravenous fluid therapy. An animal with very severe dehydration due to diarrhea obviously needs to be supported by parenteral fluids. However, there are situations in which oral rehydration solutions that consist of sodium chloride, potassium chloride, citrate, and glucose. These are the kind of rehydration solutions that are used for children because they can be given safely in an oral fashion. And yet, we'll talk about the mechanism of the combination of these electrolytes on the next slide. But suffice to say, this is when there's primarily fluid loss due to GI loss of fluid in a diarrheal condition and generally is used to manage mild dehydration. Another premise of this oral rehydration solution is obviously that the animal has to have diarrhea and not be vomiting because if you give something orally, it's just going to come right back at you. And we mentioned before, not severely dehydrated, maybe mildly dehydrated. If they're more severely dehydrated, use IV first, and then maybe maintain the animal with oral fluid replacement like this. You'll see it most commonly used in calf diarrheal diseases. And what's the mechanism of this? Well, if you look at the very simple graphic here on the right, at the surface of the uh, epithelial cell, we have right here, this is the interstitial fluid or blood, and this is the lumen. The epithelial cell has a sodium glucose cotransporter, and the presence of glucose helps to facilitate sodium and vice versa in its absorption. And so, in addition, this gets a little bit of energy into the animal that helps facilitate sodium transport by sodium potassium ATPase. So, glucose is enabling a more efficient absorption of fluids as a result of the absorption of sodium. Potassium that's in these solutions is passively absorbed, but because an animal with diarrhea can lose potassium um, in the diarrheal fluid, it is certainly indicated as well. Now let's talk a little bit about the motility situation in a diarrheal condition. I'm going to show three situations here. The intestine can be represented as a tube. If there's no motility, you basically have an easy flow of fluid from one end to the other, no resistance. Moderate rhythmic segmentation leads to a mixing, but also leads to increased resistance of the fluid and a reduced average size of the um, lumen of the intestine. And here we have the maximal rhythmic segmentation managed by the circular muscle. And we're going to talk about drugs in diarrheal conditions that can facilitate this, but most notably the opioids, that helps to enhance the segmental um, resistance, if you will, of fluid that's passing from mouth to anus, and as a result, enhances reabsorption. Now, when it comes to managing motility, this is a graphic of an intestinal smooth muscle cell, and the nerves that innervate it are cholinergic, acetylcholinergic, muscarinic. So obviously, an antimuscarinic agent can have basically a negative effect on motility. That is, coordinated motility can have an effect on coordinated motility, both the interneurons as well as in the enteric nervous system, as well as on the muscle itself. But you can see here that this type of inhibition of acetylcholine's effect would only be useful if there was uh, diarrhea associated with increased motility, not decreased motility. And we talked about in causes of diarrhea that motility most often is reduced in the case of a diarrheal condition. Now, when we come to opioids, opioids work directly to enhance acetylcholine's effect and also have a direct effect on the intestinal smooth muscle to increase particularly the circular smooth muscle segmentation. So these drugs have an effect on motility that is basically right at the final mechanism at the smooth muscle. So that's why they're such powerful agents for increasing segmentation, increasing the time it takes for water to be reabsorbed, and that's why antidiarrheal agents most commonly use an opioid. Now, sometimes you're going to see a combination of an opioid and an anticholinergic, and I just want to point this out. Oftentimes, it's because the drug companies put these two agents together in order for the opioid not to be abused. Um, Notice that the effect of an antimuscarinic agent would essentially be bypassed by an enhanced uh, motility caused by the opioid. So when you see an agent like atropine together with an opioid in a antidiarrheal product, the real reason for the anticholinergic, antimuscarinic agent is to reduce the tendency for abuse, because obviously if somebody would ingest this, they would feel more of the effects of the anticholinergic agent, dry mouth, etc. That would be a negative effect. Now, managing the aspects of a secretory diarrhea is another thing altogether, and it's useful to um, use some mechanisms to understand how these drugs work. Now, this is another one of those slides where you're going to have to stare at it for a while, listen to me as I talk about it. I'm going to try to take you through it one step at a time and essentially one drug class at a time with regards to the types of drug classes that work for secretory diarrheas. So it's useful to talk about what normal mechanisms are associated with stimulating secretion, which we mentioned in earlier videos, um, is driven by enhancing chloride and obviously sodium and water uh, secretion into the GI tract. And so, what is the normal mechanism for this? We talked about the submucosal um, uh, enteric nervous system neuron that has its effect, a positive effect in this case, on by releasing acetylcholine through the phospholipase diacylglycerol, inositol triphosphate, calcium, protein kinase C, gene regulatory proteins. We get more chloride channels. Now, there are other mechanisms such as cyclic AMP based mechanisms, which you can see here, for chloride channels to be inserted. Those are stimulated by products like prostaglandins. And so we have the G stimulatory proteins, positive effect, adenylate cyclase, cyclic AMP, protein kinase A, and enhanced insertion of chloride channels in the luminal membrane. And so that's the normal scenario. You have, in addition, the sympathetic nervous system, whose role it is to provide presynaptic inhibition to this acetylcholinergic muscarinic interaction. And so that's why sympathetic neurons can normally reduce the pathway associated with stimulation by submucosal enteric nervous system cholinergic input. Other than physiological reasons to know that, we rarely have pharmacological reasons to use sympathetic agents to reduce a secretory diarrhea, but in fact, they would have that effect. Now, remember that the other things that stimulate secretions include histamine. Histamine is obviously released by mast cells that are activated by IgE in the enteric mucosa. Histamine has a positive effect, again, through the same mechanisms as acetylcholine, basically, to stimulate a chloride channel. So the basic three mechanisms here that are positive include prostaglandins, histamine itself, and acetylcholine. Now notice that when histamine and prostaglandins are released, they have a inhibitory effect on this inhibitory input from the sympathetic nervous system. So two negatives make a positive. So release of prostaglandins and histamine lead to increased secretion. They also are, that combination also leads to stimulation of the submucosal neuron that also stimulates secretion. So there's two mechanisms regarding the prostaglandin and histamine effects. Now, what about the opioids? The opioids basically are linked to inhibitory G proteins that have a negative effect on the adenylate cyclase, reducing cyclic AMP, and as a result, reducing the tendency for chloride channels to be inserted and therefore for chloride secretion to occur. So we mentioned, let's now go through the various drug classes. The drugs such as bismuth salicylate, you might know it as Pepto-Bismol, we'll talk about it shortly, is a COX inhibitor. They would work up here, reducing prostaglandin production. Antimuscarinics, site number 2, would be blocking the acetylcholine muscarinic receptor, muscarinic type 3 receptor here, and reducing this pathway. The histamine 1 antagonists would obviously be working right here and also here, and reducing the tendency for histamine to have its secretory effects. And then opioids, as we mentioned, have a direct effect on their own receptor. This tends to be through most subtypes of opioid receptors that are linked to the inhibitory G protein and adenylate cyclase systems. So all of this leads to some manipulation of the chloride channels, and subsequent sodium and water secretion are affected. Now, because they're some of the most potent antidiarrheal agents, let's talk about opioids. And I've mentioned this before. Basically, they enhance segmentation and increase transit time. And their side effect, we often know when we use them as pain relievers, is constipation. So that is the effect they have, is to increase the transit time, increase water reabsorption, and lead to a constipating effect. They can be also anti-secretory based on the mechanism I showed you in the previous slide. They should be contraindicated when you know that there's an intestinal obstruction, because you're going to increase the tendency and the pressure around the obstructive area, and that can lead to rupture. Common opioid antidiarrheals are, for instance, paregoric tincture of opium, or the combination of an opioid, diphenoxylate, and atropine, which we know is low modal. Now, remember, I mentioned that the atropine really is not doing anything but making it less likely to be abused by humans. And it doesn't reduce segmentation because the opioid works directly on the smooth muscle. And we also have loperamide. Now, both of these are used as anti-secretory agents, and indeed, the antimuscarinic agent would have its effect on secretory types of diarrhea. So, what are the mechanisms that we have for anticholinergics being antidiarrheals? Well, they will tend to decrease segmental contraction. And therefore, and we know this as a postoperative complication, particularly in horses, they can cause ileus, that is, the absence of motility, stasis. Therefore, that makes them more likely to be useful to reduce straining, that is, tenesmus or pain associated with colonic inflammation. And as I mentioned before, they have a mechanism to secrete fluids and electrolytes based upon the slide I showed you about mechanisms previously. Their indications are really for when we know there's true hypermotility and spasm. They're contraindicated in infectious diarrhea, and their side effects include dry mouth, urinary retention, tachycardia, and CNS stimulation. Examples, the classical one is atropine, but you also see scopolamine, ipratropium, and pirenzepine as antimuscarinic agents. Now, I thought it'd be useful at this point to mention one drug that sulfasalazine, which is has a specific indication of ulcerative colitis, and it's a sulfapyridine antimicrobial that is bound to 5-aminosalicylic acid, and it releases this salicylate into the colon when it's cleaved by bacteria, and it has potent anti-inflammatory effects. And therefore also has anti-secretory effects by the mechanisms of reducing prostaglandins that we mentioned as their secretory role before. You can lead to salicylate toxicity, so this is something to be quite aware of and perhaps avoid in using these kinds of drugs, particularly in cats. Side effects include keratoconjunctivitis sicca, dry eye, granulopathies, drug eruptions, and other autoimmune syndromes that look like lupus. Now, a much more common type or class of drugs that is used are called the protectants or absorbents and anti-secretory agents. The most famous one, perhaps, is called Pepto-Bismol. You probably all have had a chance to use it at one time in your life. And it's called bismuth subsalicylate. So its mechanism, in addition to being protectant and having this this ionic metal of bismuth, is a salicylate and not a non-steroidal anti-inflammatory drug. So its mechanism is to decrease intestinal secretion of fluids. As I mentioned before, it too can cause, like sulfasalazine, can cause salicylate toxicity. So you want to be very concerned about its use in, particularly in chronically in cats. Another drug that is similar to this as a protective agent is barium sulfate, um, and it is sometimes used in GI conditions as well. Now, in this presentation, I wanted to focus on anti-secretory agents, but I did want to mention a drug that would have an effect as an anti-ulcer and protectant that we will talk about in more detail in subsequent GI drug presentations, and that is the drug called sucralfate. Sucralfate basically tends to bind to damaged tissue, ulcerated tissue, and it also has a tendency to allow healing to occur, to reestablish proper production of prostaglandins and reduce acid secretion that might be damaging the tissue. We'll talk more about that in a subsequent GI drug presentation. So in summary, oral replacement solutions can be used in an animal with moderate dehydration, and this is usually when we have a diarrheal condition but no vomiting. Opioids are the most potent antidiarrheal agents that increase transit time and therefore increase reabsorption of water, and but they're generally only rational when you do not have an obstruction and you do not have an infectious agent. So you can imagine that if you're increasing the time in which that infectious agent is in the GI tract, this could actually be a detrimental thing. Opioids are also anti-secretory. That's why they're also powerful motility modifiers and anti-secretory agents. Local delivery of salicylates, such as with Pepto-Bismol, bismuth can reduce secretory diarrheal conditions. By the way, it's the barium and the bismuth that also has an anti-secretory effect. And anticholinergics are really only logical in secretory diarrheas or occasionally in diarrheas associated with hypermotility, which, as we said in previous presentations, is an uncommon thing. So anticholinergics are included in combination drugs like opioids and anticholinergics for their anti-secretory effects, but also as an agent to prevent the abuse of the opioids.